Thank you very much, Mr. Speaker, for the opportunity to contribute to the statement. And let me also express my deepest condolences to the family of the late Charles Emisa on behalf of all of us, and in particular on behalf of the board and management of the Kolebu Teaching Hospital. Mr. Speaker, I also want to thank the minority leader for this statement. It's very timely, and he has set the tone for us to really examine the issues. Permit me to take us a bit down memory lane to remind us of something that is not too pleasant. In June 2018, it was a 70-year-old man, Mr. Prince Anthony Poku Echampong, who died after visiting 7 hospitals, including a hospital that his company supplies stationery to. He was the CEO of a stationery company, and they supplied stationery to this hospital, and he was turned away. And the explanation or excuse was the same. The then Minister of Health did his best, constituted committees to ensure that this will never happen again. Unfortunately, 8 years down the line, we have this time a younger person, strong person, an engineer, losing his life to a similar circumstance. Very, very, very unfortunate. But Mr. Speaker, when we say no bed in the hospital, what actually do we mean? A no bed could mean that there is no physical bed at the emergency. It could also mean that there is no blood if the managers anticipate that that patient will need blood, and so they want the person to go elsewhere. It could mean there is a particular skill. For instance, an anesthetist is not there, and they think that that patient will require surgery. It could mean there is no theater space. It could mean there is no oxygen in this hospital. There is no ICU bed, but we think that this patient needs ICU care. It could mean there is no stroke bed, and therefore we are telling you no bed because you have a stroke. There is no doctor at this moment, so there is no bed. Mr. Speaker, but the most disappointing part is that no bed could simply mean that the staff are not willing to work. And that is the very, very sad part. This no bed could mean that a shift is about to end and someone is not willing to admit a new patient and do all the documentation, so turn the patient away. No bed could mean that the doctor is afraid to work or is tired and feels that if he touch that patient and the patient passes away, duty of care is established legally because he has touched the patient. So see no evil. I have not touched that patient, so you cannot blame me for it. But is it really right if a patient dies in the precinct of a hospital, at the entrance of the emergency, wait there for 30 minutes, 45 minutes, and you say because you've not seen that patient, no duty of care is established? The legal brains will have to help us out. Mr. Speaker, the causes of no bed in this country has been established by previous committees under the former health minister, Honorable Kweku Ajimamenu, and I worked on that committee in my former capacity as General Secretary of the Medical Association. We all contributed to it. But still, the attitudinal problem and some few other factors have brought us this far. You can group the causes into structural, into functional, and one of attitude. If you talk about structure, the WHO recommends that we should have about 2 to 5 beds per 10,000 population, hospital beds. In Ghana, we have 0.9 beds per hospital population. So practically, it can be that our beds are simply not adequate. But when you go to the functional issue, you can say no bed at the emergency, but there may be a bed on the ward. There may be a bed on another ward. And it's just an attitude of transferring a patient from here to that ward so you can create space. And people are not willing to do that. Mr. Speaker, as mentioned earlier, Kolebu Teaching Hospital, where I preside as the chairman of the board, was the last place that this man had his last breath. And we are very sorry about this. We have taken our own measures. We have interdicted 4 staff, and we have set up a committee to investigate. The Minister of Health, as alluded to by the Deputy Minister, has also set up a very high-level committee headed by the revered Professor Ajuman Bedu Akosa, Professor Ajuman Bedu Akosa, and they are working to see the exact cause of this particular incident. But I'm also proud to announce that to bring a comprehensive solution, building on the effort of previous ministers, the current Minister of Health had already set in motion a team to solve this situation comprehensively. And they are coming out with a document that is going to be looking at a national integrated bed management and referral coordination system. This will be backed by IT and is going to allow us at the real time to be able to tell the categories of bed that are available in a particular hospital. Whether you don't have stroke bed or ICU bed or bed for a pregnant woman or for a child. This work has been ongoing. It is unfortunate that while it was in its final weeks, this incident has happened. And the minister has asked the group to quicken up their work so that he can make a major announcement on this to bring a comprehensive change that would help us. It will rope in the ambulance service so that when the ambulance picks a patient, they don't ask the patient or their relative or a doctor in a small private hospital, can you tell us which hospital is willing to accept this patient? This is the current situation. I have had calls from a lot of colleagues here. They need a patient moved to Kolebu, and their response will be that there is no bed at Kolebu emergency. But when I call, there will be a bed. Why? So this is what this problem, solution that the minister is bringing is going to solve. And I'm pleading that Parliament will give the minister all the support needed so that this problem can be solved once and for all. Mr. Speaker, I will conclude by saying that our ambulance service, by their acts and by their function, may also need to be reviewed. Currently, they do scoop and run. What it means is, at an accident scene, they can pick you up, but they can't even set a simple IV line to give you fluid. For this patient who was being moved from hospital to hospital, if a simple normal saline was running, this patient could have survived. The minority leader mentioned his BP at the beginning. At Kolebu, when they checked the BP in the ambulance monitor, it had come down to 84/56. That is someone who is just about dying. So if they could at least set a line and run some fluid in transit, a lot of patients will survive. So the model that allowed them to only scoop and run must be changed, and their training must be upgraded so they have paramedics that are specialized to be able to provide some basic care. But in conclusion, attitude is our biggest problem. All of this will not change if the attitude does not change. May I stand on this to appeal to my colleague health workers. Look at that next patient, that it could be you, it could be your father, it could be your mother. It doesn't have to be another doctor calling you before you create a bed and accept the patient, because the one that can call, maybe you may be the one unconscious who will call on your behalf. Thank you, Mr. Speaker.
Honorable members.